First of all, I'd like to thank the organizing committee for the kind invitation to participate in this fantastic meeting. In the next few minutes, I'm going to present two challenging cases in LAA occlusion. These are my disclosures. But first of all, I'd like to point out that the success rate of LAA occlusion is really high. You can see in the slide the success rate in the PROTECT AF trial, in the CIP registry, and the PREVAIL trial using the Watchman device. In all of them, the success rate was over 90%. In the same way, the reported success rates with the ACP device are always over 95%. Anyway, the difficulties that we do find with this procedure are mostly related to anatomy. As it has been explained this morning, in more than 2/3 of cases, the LAA consists of 2 or more lobes, which are usually located in different planes. And also, the shape of the LAA is extremely variable. Several classifications about the morphology of LAA have been proposed, but the most widely used is the one that has been explained this morning. As you remember, the cactus morphology, the chicken wing, the cauliflower, and the windsock. In the chart, we can see the frequency of each morphology according to Dr. DiBiase's study, but this number can change if we use a more specific definition. Furthermore, there are some morphologies that are even difficult to include in any of these previous classifications, as we can see in the slide. The first case I'm going to present is a chicken wing LAA occlusion. Regardless of the definition used, what makes a chicken wing difficult to occlude is an early and severe bend, and the prevalence of what we can call difficult chicken wing is around 12% according to Dr. Fraser's study. Because most of the time, in a chicken wing LAA, the bend is not severe and is located distally. This allows the device to be deployed in the landing zone as usual. This is a case, an example of a case that you can see that the bend is not severe and is located distally. In this case, we use an amulet device, a 25mm device. Initially, we deployed the lobe of the device in the distal part. You can see that it's inside. Here, you can see that it's inside the chicken wing. So there was no tension on the device. We can see the hockey puck shape. So we decide to deploy the device more proximal, and now you can see that the shape has changed. Now we have a tire shape, device shape, and we can see that there's tension on the device. So we decide to release the device at that position with a good result in angio and also in echo. Here is another example of a chicken wing LAA, but again, the bend is not severe. The angle is less than 90 degrees and is located distally, so it was easy to close it with a Watchman device. But in contrast, I'd like to present a difficult chicken wing. This is a chicken wing in which you can see that the bend is proximal and is severe. If we try to deploy the device in the proximal part in the landing zone as usual, the device is not going to have enough room, so it can be unstable and it can embolize. So therefore, we need another strategy. And here comes my first question. So do you think this difficult chicken wing can be occluded? Impossible? Call the surgeon to the low chicken? Yes, try ACP. Yes, only with a Watchman device. Yes, only with a Lariat device. Please vote. Okay, so I agree. You know, for the Watchman, it's going to be a difficult case. The length is a small length. With Lariat, we can try, but of course, not only with Watchman, not only with Lariat. So we will try an ACP. Can we go back? So I will explain step by step and tip and trick to close this difficult chicken wing with the sandwich technique. Let's begin with the echo. For the echo, I recommend to pay special attention to the 135-degree view. This is not a common and useful projection in most of the cases for ACP, but in this particular morphology is vital because it's the one projection that can show the bend and the location of it. Regarding the transeptal, again, we must repeat that it should be inferior and posterior, because this allows the sheath to be moved into the LAA, so into the chicken wing. Regarding the projections, again, in contrast with the usual cases of ACP, I recommend to use a caudal view, because in the caudal view we can see the distal lobes, so we can see clearly the bend of the chicken wing and all the location of the other structures. Another option is to perform a rotational angiogram, so you can see clearly, the bend and all the morphology of the chicken wing. And here comes the second question. In a case like this, which size would you use of the device, an ACP device? 2 millimeters larger than the largest angiographic OT measurement, 3 to 6 millimeters larger, 2 millimeters smaller as I'm going to deploy it in the chicken wing. Sizing is not so important, I always use a 24. So I agree. I think that the idea in this type of chicken wing, difficult chicken wing, is to deploy the device at least partially inside the chicken wing. So we recommend to use a larger device, oversizing from 3 to 6 millimeters larger to the largest measurement in angio or in echo. So now we need to advance the sheath. I recommend to use the pigtail as a guide wire. This is like the watchman technique, because we want to have the sheath just toward to the opening of the chicken wing. So for that, we need to do an extreme counterclockwise rotation, and it's safer to do that with a pigtail as a guide wire. In this position, we deploy the device, and we try to deploy one side of the device inside the chicken wing and the other side against the contralateral wall in order to have enough tension to deploy the disc. Here you can see that in echo, normally in the 0 to 90 degree views, it shows that the device is flat and with a position, and when we move to the 130 view, it tends to show the rotation of the lobe inside the chicken wing. This is another example just to remember all the steps. We recommend the caudal projection. We advance the sheath over a pigtail as a guide wire. We try to deploy one side of the device inside the chicken wing, the other against the contralateral wall. So we have enough tension, as you can see here on the left panel, that we have enough tension to pull the disc and to deploy the disc out of the ligament of Marshall with a nice result. This is the final result in this second sample, and you can see that it's totally occluded. To continue, I'm going to present a Cactus LAA occlusion. The Cactus morphology is frequent, and in most of the cases there are no problem. We can close a Cactus LAA with any device, but sometimes it can be difficult, especially if there's a bifurcation of the Cactus in the proximal part. So if there's a bifurcation in the proximal part, things can turn ugly, especially if we are planning to use a watchman device. So this is an example of a Cactus LAA. You can see here that there are two lobes with a proximal bifurcation of the lobe with different length of each lobe. So my question here is, do you think this Cactus LAA can be occluded? Impossible with a device? Call the surgeons. Yes. Any device except for watchman? Yes, try an ACP or an amulet device. Yes, try a lariat. Yes, give watchman a try. Okay, so I agree that probably is an easy case for an ACP or an amulet, but I want to show that even with a watchman device, this try on morphology can be close, or at least we can try. So again, for the echo, we recommend to do all the projections, because especially in the 135 degree, you get a good impression of the length of the lobes, and it can help to decide which lobe you are going to deploy the device. For those of you not familiar with the watchman device, let me explain that we need the same length, at least the same length, as the diameter of the device. So if we are planning to use a 24, we need at least 24 millimeters of depth. Again, the transeptal should be in the inferior and posterior part in order to allow the sheath to move inside the LAA. And again, the caudal projection gives a good impression of the distal lobes. Here you can see that there are two lobes with a proximal bifurcation of the lobes. So we explore the inferior lobe. Here you can see that the sheath is inside the distal lobe, but it's not coaxial to the neck of the LAA, and also we don't have enough length to deploy a 24 millimeter device. So we decide to use the upper superior lobe. We have enough length and it seems to be in a better position. We deploy the device. And when we deploy the device, we inject some contrast, and we can see that there's a gap. There's a leak there, so we are too deep, so we are covering the upper lobe, but the lower lobe is open. So here, there's another question, the last question. So what would you do at this point? Leave it there, it's not so bad, tag test and see what happens. Partial recapture, complete recapture, and forget it, you are not going to make it. So most of you recommend to do partial recapture. At this point, we decide not to do any recapture, not partial, not complete. We decide to do the tag test, because many times when you perform the tag test, it can move a little bit. So we decide to try initially the tag test. You can see the tag test on the left panel. You can see that the device is stable, but it moves a little bit. So when we inject contrast, in comparison with the previous angio, the leak was smaller. We check in echo. This is in the only projection, in the 135 projection, and the only one that we can see that there was a leak, a gap, and it was smaller than 2 millimeters, so we decide to release it at this point. You can see here the release of the device. And let me point that here, if you pay attention to the screw, as soon as we release it, it moves a little bit, it rotates. So with this little rotation, we get a very nice final result with complete or almost complete coverage of all the appendage. Here you can see in the 135 that the device has rotated a little bit, and with this rotation was able to occlude completely the appendage. So in conclusion, let me say that the LAA morphology is extremely variable. This can make LAA occlusion a challenging procedure in selected cases, but however, we need to remember that LAA occlusion success rate is over 90%. Thank you for your attention.
I'm happy to share with you some interesting cases, but I think what I'm going to try and do is center on the topic that I was given, which was challenging morphologies. So I've changed that a little bit and called it varying morphologies, the challenges of closure. And what I'd like to do is, aside from mentioning my conflict of interest, I'd like to have a think about what is in fact challenging morphology. And that is, I think, morphology that causes us to behave in an unusual or difficult fashion in order to achieve the optimal results in the absence of complications, achieving what we want to achieve without any complications. Now, let's make the assumption that everybody in this room is an outstanding operator, because I'm sure actually they all are, and we can assume that all the operators have the required skill set. So if that's the case, challenging morphology must be device-specific. That means that it's going to be challenging for device A and not necessarily for device B, or vice versa. So what is the challenging morphology for the ACP? I'm going to center on the ACP in this talk, because I think it's beyond that, it's beyond the scope of the time that I have. So I'm going to divide that into 3 steps. The first is the, sorry about that, back, the act of deployment. That means getting it to go where I want it to go. That means there's difficult angulation, that the space or the volume for lobe expansion is inadequate. and that may be dependent on the depth, the diameter, or the breadth of the neck. The second thing is having the device actually having difficulty getting it to achieve what I want it to achieve. Not getting there, but actually once it's there, can it do what I want it to do? And that can be based upon severe funneling with the landing zone much smaller than the ostium, or it could be extreme diameters, either extremely large or extremely small. That means that this is a challenge for this device to achieve the result. And the third thing is that the anatomy is difficult to understand. That's a challenge for me because I have no idea whether I can achieve 2, and if I can achieve 2, whether I can achieve 1, whether I can get where I want to go. So what, therefore, is non-challenging morphology? That's a challenge. That's morphology that I understand the anatomy. I know where to put the device, and I have no trouble putting it there. So that's non-challenging. How can I shift challenging morphology to non-challenging morphology? Number one is I need to understand the anatomy. I need to understand where the device needs to go, and I need to appreciate how to manipulate the sheath in the device so it can be deployed in the desired position. What, therefore, are the unresolved issues? They are the anatomies that are inappropriate for the ACP, speaking specifically about the ACP, that they're either too large or too small, or that they're extremely funneled. So let's look at our first case, and I'm going to ask the question, do I really understand? So this is an 82-year-old man with permanent atrial fibrillation. He's got a CHADS-2 score of 2, and his warfarin was discontinued due to ongoing severe rectal bleeding. So our first shot is an RAO shot. We can see our appendage. We can see it not continuing to run, but that's okay. We're going to move on. And here we can see an RAO cranial shot. We can get a good image of the appendage here. We can see it's taking a kind of right-hand turn over this point, large dimensions, bit of hang-up in the distal portions. When I look at the echo, this is the measure that I get. This is an 80, which is sort of a relatively short-axis view, and I'm getting something that says to me that the ostium here is 2.2, and something that says that the landing zone is 2.3. That means that the ostium is a little bit smaller than the landing zone. And those are the numbers I'm getting, 2.3 and 2.2. So then I do my measures, and I get an image that says to me, my landing zone is 22 up here, or 23. Oh, sorry, it's even 24 up there. But my ostium is 28.5. So at this point, I try and say, well, is it funneling or is it coming down? What have I done that doesn't make sense? I've got some sort of discrepancy that doesn't allow me to match them. When my echo landing zone measures are equal, but my ostia are not equal. So at that point, I ask the question, and my first question is, how would you size the device? Based on the landing zone, based on the ostium, or I can live with discrepancy? So as soon as we have the answer, we'd love to have it up. So based on the landing zone, ignore the ostium is the general suggestion, and that's actually been the standard teaching of the ACP. I've shifted a lot in terms of my approach. So can we have my next picture up? So I actually couldn't live with discrepancy, so I did an LAO shot, and this is actually what I received. I've actually got the reverse chicken wing, the chicken wing that goes initially where there's a gentle turn this way, but then it actually comes back up here. And the overlying, if you look at the next image, you can see that, in fact, this overlying distal lobe was causing discrepancy in my view, so that when I look here, I can actually see just here the PV ridge. And so I'd completely missed the true ostium and hadn't worked out where it needed to go. Once I understood what needed to be done, in spite of the fact that it was a reverse chicken wing, there was enough distal position on this side for me to position my sheath. Then I used my standard 4-point deployment technique. Number one, unsheath the lobe. Following that, counterclockwise, I'll give a test here, actually, and then uncounterclock it so that we can position in the correct angle. Push the device out. And at this point, we can actually see very clearly that the ostium is here and the PV ridge is just sitting here now that we've not allowing filling distally. The other interesting thing is to watch how it settles, and the device actually, the amount of compression on the device reduces as it sits in position. And then we can pull out, watch it shift back a little bit with good occlusion, with the PV ridge between the lobe and the disc. Final release and final shot. I'd run out of contrast. So my conclusions on this case are really, as we know that the anatomy is extremely variable, you need to think on your feet. Don't disregard discrepancies of information. If their two modalities are not matching, something's wrong. You're doing something wrong. Stop and rethink. Take advantage of all the different modalities that you have at your disposal. And once we understood, it really wasn't very challenging. So we're going to move on to the next case, which is I'm calling pushing the limits. This is an 84-year-old woman. She's a CHADS-2 score of 5, and she's had a massive lower GI bleed, so she was referred for left atrial appendage occlusion. Have a look at our initial echo. We get a look of a sort of a 60 short x-axis. We can see that the PV ridge seems way up here, so it's quite a long way up. And when we do a measure, we're getting a measure that comes out to be about 3.1 with 1.8 at the landing zone. So I'm actually going to try and deploy a device that has to cover with a disc this 3.1, or so I thought. And then we moved around, and here you can actually see my X-plane giving us two views. This is a zero view, and this is a 90. And I'm actually getting 3.8 out at this ostium with a measure of 3.2 at my standard position and 2.8 or nearly 2.9 at just a bit further in. And on this, we're getting demonstrating the eccentricity of the structure, getting our 3.1 and our 2.1. So there are two important issues. Number one is that this is extremely eccentric, and number two is it's very funneled. We then went off to our angio, and this is our caudal shot. We don't see very well the the proximal neck, but we can see the distal lobes. So we moved to a cranial shot. And this is an interesting shot because it shows us that we've got the ostium way back here, and so therefore we'd want to have to try and cover all the way back here. But there is a very interesting looking ridge here, which may be a friend. Our measures initially came out at 25. My initial decision was, even though this is a little bit deep, this is where I would like to put the device, because I don't think I could sit it anywhere else. I need to take advantage of this little ridge, this indent, but that gives me an ostium of 43. Is that something that I think is doable? So I therefore shifted and said, well, that I'm not going to do 43 with a 36 millimeter disc. That's going to come down to 33 when I measure it. So is this an acceptable result? Is this open enough for me to think that this is an acceptable result? So this anatomy is challenging the technology. So my then next question is, how would you size the device? Based on the landing zone short axis, based on the landing zone long axis, based on the ostium. This is beyond the limits of the technology, and I can live with discrepancy. Having remembered that we've got a 1.8 landing zone in one axis and a 25 in another axis. And the answer is based on the landing zone long axis. Okay, the truth is that I certainly use personally a mixture of all of these, although I've, as I mentioned before, taken more and more concern of the ostium, so that if I have a very severe funnel and I didn't have the long axis images, I probably would have taken close to a 30 anyway, even though I was getting an 18 or a 21 in the short axis. My image, right. So here what I've done is I've taken the 30. You can see me now opening to ball once again, unsheathed to ball. Second is a test to see where I'm sitting. Third is we're going to go to a counterclock rotation to try and achieve position. My challenge at this point is to try and find that ridge. The technical demand upon me here is really to get this device to find that ridge. So I then take my shot, and I'm not really very happy that I found the ridge. I can see my device angulation is too superior, and that in fact what I'm getting is occlusion distally, but I'm not convinced that I'm actually going to be solidly hooking up there. So I then, just for the sake of it, you can see it's already out, but retracted it back out in order to collapse it, and then repositioned. So I'm not going to ask you whether you should reposition or upsize because I'm already at 30. So I'm now attempting again with slightly less counterclockwise rotation at this point to find that ridge. And here I'm feeling happy that I've caught the ridge. As you can see, there's degree of compression, not as much as I would have liked, even though, if you recall, this was a 25 or a 1.8. So the test is going to be as I bring the disc out, and this is my tug test, if you like, I extract it, so I want to watch the waste come out from inside. There it is. And now I know that I'm coming back. I know I will never get to the PV ridge. So I'm going to assess where it is that I'm sitting. I'm still happily sitting on that ridge there. I suspect I'll be more occlusive once I release it here. My inferior portion, both of the lobe and the disc, are sitting very nicely. My question then is this acceptable for me? I'm going to have a quick look at it on echo. You can see that in one view, there seems to be very little compression. However, in the other view, there's very deep, serious compression. And so I've got good positioning on both sides. And now, at that point, I was happy, release the device, and watch it bounce back in. There you go. It bounces back in to close up that hole. You can see the same thing sitting here. See this gap, and it falling back in as soon as it's released. Now let's look at the final result. No flow behind the lobe, a little bit of flow behind the disc. Change the angle to get a better view of it, and let's look at it echo. And this is my final result with good compression and good positioning on either side with this small ridge left out. I was happier with it because it wasn't actually coming in that angle and sitting there. So I'm going to, at that point, say that we can overcome the challenges by improving anatomical appreciation, better use of CT, MR, and experience. Experience allows us to see those things. We want to provide devices that can cope with a wider range of sizes, larger devices, smaller devices, and a larger range of devices or ability of the device to cope with lobe-disc ratios that are different. And we'd like to see greater delivery flexibility, probably with Sheath, but potentially with an alternative approach. Thank you. Challenges are what make life interesting. Overcoming them is what makes it meaningful.
Just your opinion, do you think in future you would benefit from, let's say, simulation, when you sit in front of a computer and you could implant on a 3D model? Do you think this makes sense for education, or do you think it's the situation in the patient with all the variables which make the difference?
I think that there's, as an educational tool, simulations and 3D and holograms and 3D printing are all very exciting and have enormous amount to contribute. In practical day-to-day life, I think that there is benefit in extreme cases. And so, but the information that I received today from the transesophageal echo, and we have fantastic level of transesophageal echo, is not enough for me to pick those extreme cases. I would not have determined that unless you were looking at those images, right? The discrepancies. In the majority of cases, you don't pick it.
I saw your case when you had this counterclock rotation and you made it less, and then you had the successful. This could be something you could learn from a simulator, maybe how much to rotate, and you could maybe leave out one implant try.
I agree with you. I think that on extreme cases, that's a very interesting option. The question and challenge is going to be if you adopt the approach of doing CT scans or MRs on all of these beforehand, you will be able to pick the cases where you're going to benefit from that. I think in the massive cases, that's not going to be the case.
Okay, thanks. Thank you a lot.